Hey everyone, ready for another deep dive? We're tackling some pretty essential bacteria stuff this time. You know, the kind that pops up on those surgical resident exams.
Ah, yes, those exams, they can be a beast. But understanding bacteria is super important, especially in surgery.
Right. It's like knowing your enemy on the battlefield.
Exactly. And knowing them starts with, well, knowing how to classify them.
Oh, I remember bacteria classification from Micro. It was a bit of a maze, honestly. What are the crucial things we need to know for surgery, though?
The big one is the difference between gram-positive and gram-negative bacteria. Knowing which is which helps us choose the right antibiotic. Because those antibiotics need to actually be able to get through the bacterial cell wall to work.
Okay, so the gram stain tells us that, right? That purple or pink stain.
Yep. And there's a mnemonic I used to use for remembering which bacteria is which. It's a bit long, but it works. All cocci are gram-positive except Neisseria. All bacilli are gram-negative except Clostridia, Mycobacteria, and a few others.
Mnemonics are lifesavers during exams. Okay, so that's classification. Now let's talk about something a bit scarier, sepsis.
Ah, sepsis. Yeah, every minute counts with sepsis. The faster you can act, the better the chances of survival for the patient.
Which is where that sepsis 6 protocol comes in, right?
Exactly. Those 6 steps, if you can do them all within the first hour of diagnosing sepsis, are crucial. High flow oxygen, blood cultures, broad spectrum antibiotics.
Hold on, slow down. What are all 6? And why is each one so important?
Okay. So you got your high flow oxygen, get that oxygen to the tissues. Then blood cultures, got to know what you're fighting, right? And while you're waiting on those, you hit them with IV broad spectrum antibiotics.
Makes sense so far. That's 3. What are the other 3?
Measure serum lactate. See how much damage is already done. Then a full blood count, got to keep an eye on that. And then start IV fluids, get that circulatory system supported. Oh, and monitor urine output to assess those kidneys.
Phew. Okay, got it. All within the first hour, no pressure. Now let's shift gears to some of the bacteria we actually see a lot in surgery, staph, and strep. How can we tell them apart?
So they're both coccus, those round guys, and they're both gram-positive, but staph bacteria hang out in these little clusters like a bunch of grapes. Strep, on the other hand, form chains.
So like a pearl necklace. Right, I think I can remember that.
Exactly. And another key difference is that staph is catalase positive. Strep is catalase negative.
Okay, that's a bit more technical. Remind me, why do we care so much about these two?
Well, Staphylococcus aureus specifically, it's the cause of tons of surgical infections. Wound infections, cellulitis, even some really nasty stuff like endocarditis or osteomyelitis.
Oh yeah, those are bad news. And then there's MRSA, right? What makes that one so difficult to deal with?
MRSA has basically become resistant to a bunch of our go-to antibiotics. Methicillin, penicillin, even cephalosporins.
So what do we use?
We often have to turn to stronger antibiotics like vancomycin. And unfortunately, MRSA isn't the only resistant bacteria we're dealing with these days.
Oh, there are more, don't tell me.
VRE, vancomycin-resistant enterococci, and CPE, carbapenem-resistant enterobacteriaceae. They're both becoming major concerns, especially in hospitals where antibiotic use is high.
Yikes. So what can we do to fight back against these resistant organisms? It feels like a losing battle.
We're not powerless. One strategy is MRSA screening to prevent those infections from happening in the first place, before they even set foot in the operating room.
Okay, that makes sense. How does MRSA screening actually work?
Well, in the NHS, every patient scheduled for surgery gets screened for MRSA. We just take a simple nasal swab.
Right, because people can carry it without knowing, right?
Yep. A lot of people carry S. aureus normally, and a small percentage of those carry the resistant MRSA strain. Screening helps us catch those cases.
And what happens if it comes back positive? Do we postpone the surgery?
Not always. If it's positive, we start what's called a decolonization protocol to reduce the amount of MRSA they're carrying.
Decolonization. Sounds intense. What does that involve?
It's actually pretty straightforward. Patients use mupirocin nasal ointment 3 times a day for 5 days, and they also use a chlorhexidine body wash daily.
So we're hitting it from 2 angles, the nose and the skin.
Exactly. It helps to significantly reduce that MRSA.
Clever. Okay, let's get back to strep for a sec. What should we know about that one?
Streptococcus pyogenes, also called Group A strep, is a big one in surgery. It often causes cellulitis and can even lead to necrotizing fasciitis.
Oh, wow, necrotizing fasciitis. That's scary. But are all strep bacteria that bad?
Group A strep is a common one, and it can cause a whole range of problems, from a simple sore throat to scarlet fever. It can even cause post-streptococcal glomerulonephritis, which affects the kidneys.
Wow, it really does it all, huh? Okay, let's move on to mycobacteria. I remember those being a bit tricky. What makes them stand out?
Mycobacteria are unique because they're acid fast.
Acid fast. What does that even mean?
Imagine you're trying to wash dye out of a fabric, but it just won't budge. Mycobacteria hold on to certain dyes even after being treated with acid and alcohol.
Okay, that's a pretty good image.
They're also slow growers, which can make lab identification quite a waiting game.
So they're stubborn and slow. And there are different types of mycobacteria, right?
We classify them as typical and atypical. Typical mycobacteria include Mycobacterium tuberculosis, the one that causes TB, and Mycobacterium bovis and Mycobacterium leprae. Atypical mycobacteria are a diverse group that can cause a variety of infections, especially in people with weakened immune systems.
So why is this distinction important for surgeons?
In your practice, you'll want to be on the lookout for atypical mycobacteria in cases of lymphadenopathy, especially in children.
Good to know. How do we even detect these mycobacteria? Is it just looking for them under a microscope?
We can use a stain called the Zeal-Nielsen stain to visualize those acid-fast bacteria, but that's not always enough. We often use more advanced techniques like PCR or interferon gamma release assays.
Okay, so we've got a few tools in our arsenal. What about treatment? Is it the same for all types?
Treatment depends on whether we're dealing with a typical or atypical mycobacterial infection. For TB, we use a combination of antibiotics, usually for 6 months. The typical regimen is rifampicin, isoniazid, pyrazanamide, and ethambutol. Atypical mycobacterial infections often need prolonged courses of clarithromycin, rifampicin, and ethambutol.
6 months of antibiotics, wow.
And sometimes we might even need to do surgical excision, especially for infected lymph nodes. Just remember that incision and drainage are a big no-no. They can cause chronic issues.
Okay, noted. Different bugs, different strategies. Let's move on to our final bacterial family for today. Clostridia. Why are these guys important?
Clostridia are a fascinating bunch. They're bacilli, so rod-shaped, and they're gram-positive.
So they love that purple sting, like the others we've talked about.
Exactly. But here's the thing. They hate oxygen. They're what we call obligate anaerobes, and they can form spores, which helps them survive in harsh conditions.
So they're like little survivalists. I know they're found in the soil, right? How do they end up causing problems in humans?
They thrive in environments like decaying matter, just waiting for a chance to enter our bodies. Usually this happens through wounds or by ingesting contaminated food, and their main weapon is the exotoxins they produce.
Exotoxins.
Basically poisons that can wreak havoc on the body.
Got it. So which Clostridia species should we be familiar with?
There's Clostridium tetani, which causes tetanus, those painful muscle spasms. Then there's Clostridium botulinum, which causes botulism.
Wait a minute, botulism, isn't that what Botox is made from? How can something so dangerous be used in, cosmetic procedures?
It's true. The toxin produced by Clostridium botulinum can be deadly in large amounts, but in very tiny controlled doses, it can be a useful tool.
Okay, that's both terrifying and fascinating. How does Botox actually work, and what are some of its uses in surgery?
Botox, or botulinum toxin, blocks the release of acetylcholine, which is the neurotransmitter that tells muscles to contract. By blocking those signals, it essentially paralyzes the muscles, and it's surprisingly versatile in surgery. We use it to treat things like anal fissures, achalasia, which is a condition that affects the esophagus.
Okay, so it has a lot of uses. What about the other Clostridia species?
Right. We also have Clostridium perfringens, which can cause gas gangrene, a serious infection where the tissue actually dies and gas is produced. And we can't forget about Clostridium difficile, or C. diff. This one causes pseudomembranous colitis, a big concern in hospitals, especially after antibiotic use, because it can lead to severe inflammation of the colon.
So clearly, Clostridia is a force to be reckoned with. Let's circle back to that necrotizing fasciitis you mentioned earlier. What causes it, and what's the treatment?
Necrotizing fasciitis is a scary infection that attacks the fascia, the connective tissue that surrounds muscles and organs. It spreads quickly, leading to tissue death. It's often caused by group A strep, but Staphylococcus aureus can also be involved.
So it's a fast-moving infection. What should we be looking for to catch it early?
Early on, the signs can be subtle, but keep an eye out for intense pain, swelling, and redness that spreads beyond the initial injury. Later, the skin might become discolored or blistered, and you might even feel a crackling sensation because of gas production.
Yikes, that sounds awful.
Uh-huh.
How do we treat it?
Necrotizing fasciitis is a surgical emergency. First, we stabilize the patient, airway, breathing, circulation. Then we get them into surgery for debridement right away. High-dose 4V antibiotics are crucial, and sometimes we even use hyperbaric oxygen therapy to give the tissues a fighting chance.
Wow, so it's a real team effort.
Absolutely. And there's a specific type of necrotizing fasciitis called Fournier gangrene that we should mention.
Fournier gangrene, what's that?
Fournier gangrene specifically targets the scrotal and perineal area. It often starts as a seemingly minor infection that explodes into a full-blown emergency. Early recognition and aggressive treatment are absolutely key here.
Okay, that's a lot of information about some pretty serious bacteria. How are we supposed to remember all of this for the exams?
Don't worry, we're just laying the groundwork here. Now it's about making connections, applying these concepts to real-life scenarios.
Right, it's not just about memorizing facts, it's about understanding them.
Exactly. Think about how each type of bacteria acts, what makes it unique, and how that impacts the diagnosis and treatment in surgery.
This deep dive has been really helpful. Any last words of wisdom before we wrap up this section?
Just remember, the world of bacteria is constantly changing. Antibiotic resistance is a growing problem. As future surgeons, you'll be on the front lines of this battle. Stay informed, stay curious, and be ready to adapt.
That's a great point. The fight never really ends. But I think this deep dive has given us the knowledge we need to face those challenges head on. We'll be back in a bit to cover even more essential surgical concepts, so stay tuned.
And don't forget about choosing the right antibiotic, especially with those resistant bacteria we talked about. It's like, picking the right tool for the job.
Yeah, that's something I always found tricky. Picking the right antibiotic for the specific bacteria can feel overwhelming. What are the key things to keep in mind?
Well, think of it like this. We're detectives trying to solve a microbial mystery, right? First, we need to identify the culprit. Is it gram-positive or gram-negative? Aerobic or anaerobic?
Okay, so we're narrowing down the suspects.
Exactly. We also have to consider the location of the infection because some antibiotics are better at penetrating certain tissues than others.
Makes sense. We want to make sure the antibiotic can actually reach the infection. What about antibiotic resistance? How does that play into our decision-making?
Antibiotic resistance is a huge challenge these days. We always have to be aware of local resistance patterns, which can vary from hospital to hospital.
That's where our microbiology colleagues come in, right?
Exactly. They give us the intel we need based on the susceptibility testing. They're lifesavers.
They really are. Okay, let's move on to wound healing. It's a complex process, but so important for surgical outcomes. What are the key stages we need to know?
Wound healing is this incredible biological process. It happens in 4 overlapping stages. First, we have hemostasis, where the body stops the bleeding with clotting. Then comes inflammation, where the immune cells rush in to clean up and fight off any invaders.
Wait, inflammation is a good thing in wound healing. I thought we always wanted to minimize inflammation.
It's actually crucial for healing. It's our body's natural defense, but it needs to be controlled, of course. Eventually, it subsides as healing progresses.
Okay, that makes sense. So what happens after the inflammation starts to calm down?
Next is proliferation, where new tissue starts forming. New blood vessels sprout, granulation tissue fills the gap, and fibroblasts lay down collagen, the building block of scar tissue.
So that's when the wound starts to close up and look less angry?
Yeah, exactly. And lastly, we have remodeling. This is where the scar matures and reorganizes.
Does that happen quickly?
It can actually take months or even years for the scar to become stronger and less noticeable.
Okay, so those are the 4 phases. Hemostasis, inflammation, proliferation, and remodeling. What are some of the things that can delay wound healing? I know there are quite a few.
Oh yeah, there are a lot of potential culprits. Infection is a big one. It disrupts the whole healing process. Poor blood supply can also delay healing.
Right, the tissues need oxygen and nutrients to repair. What about things like the patient's overall health? Can that affect healing?
Absolutely. Things like diabetes, malnutrition, and immunosuppression can all impair wound healing. Certain medications, like steroids, can also slow things down. And as we get older, our bodies just don't heal as quickly.
So it's a complex interplay of factors. Now let's talk about surgical site infections, or SSIs. They're every surgeon's nightmare. What can we do to prevent them?
Preventing SSIs is a top priority, and it's a multifaceted approach that starts even before the patient gets to the operating room.
So it's more than just being super careful with sterile technique during surgery.
Sterile technique is crucial, of course, but we also need to optimize the patient's health beforehand. For example, controlling blood sugar in diabetics, making sure there are no nutritional deficiencies.
Right, so the patient is in the best possible shape to fight off infection. What about during the surgery itself? What can we do then to minimize infection risk?
During the surgery, meticulous surgical technique is essential. Gentle tissue handling, minimizing any foreign material left behind, good hemostasis. These all play a role. And we often use prophylactic antibiotics to give the patient an added layer of protection.
So we're stopping bacteria from entering the wound and also making the environment less hospitable for them. What about after the surgery?
Post-operative care is super important too. We have to keep that surgical site clean and dry, watch for any signs of infection, and make sure patients understand how to care for their wound at home.
So it's a continuous process. Now, what are the most common bacteria that cause SSIs?
Usually it's bacteria that live on our skin or mucous membranes, or sometimes those found in the environment. Staphylococcus aureus is a big one, as are other Staphylococci and Streptococci. We also see gram-negative bacteria like E. coli and Pseudomonas aeruginosa.
So it's a whole cast of characters. How do we know which one is causing the infection?
Well, we start with clinical judgment. We look for the classic signs of infection: redness, swelling, pain, warmth, and drainage. But to be sure, we take a sample from the wound and send it to the lab for culture and sensitivity testing.
Okay, so the lab gives us the definitive answer. Then how do we choose the right antibiotic?
That's where the sensitivity testing comes in. It tells us which antibiotics will actually work against that specific bacteria. We also consider the severity of the infection, the patient's overall health, and any drug allergies they might have.
Okay, so a lot of factors go into that decision. To all our future surgeons out there, we wish you all the best on your journey. Stay curious, stay passionate, and remember, you're not alone on this path. We're all in this together. Thanks for joining us on this deep dive, everyone. Until next time.